My name is Colleen Hinkleman, and I'm from Mercy Behavioral Health, and I would like to welcome you to the breakout session 5, the Transgender Health for the Emergency Medical Team. And I would like to introduce Dr. Kyle Duff. He is a board-certified family physician based in Washington County. He is a member of the American Academy of Family Physicians and the Pennsylvania Medical Society. He received his MD from the University of Pittsburgh School of Medicine and his BA from Stanford University. He is a chair of the Washington County Gay Straight Alliance's Health Committee and is involved in local health advocacy extending into Allegheny County. His other interests would include preventive medicine and pediatrics. And also joined is Alexandria Lynn. And so enjoy your time.
Before you clap or anything like that, just I want Alexandra to introduce herself more fully. Alexandra, because you're a co-presenter today.
Yeah, I feel like I have no bio that's relevant, but I'm a chemical engineer, 26 years experience, professional engineer in the state of Pennsylvania, and I do water treatment for cities across the US and Canada. But in this regard, I'm representing the transgender community, and we co-present this as a course for EMTs. And I kind of give my perspective, and then Dr. Kyle can kind of take the medical perspective. So we kind of tag team.
That's right. So most of what you'll see today is pulled from an actual course titled Transgender Health, the Emergency First Responders, that is for CE credit for EMTs and other emergency responders in the state of Pennsylvania. So this does not qualify for that credit, but if you were, at any point, please come talk to me if you'd like your local emergency department to receive this training or something very similar to it. We'd be happy to bring it to you. Anyone here currently have a history in or currently work in emergency health services, crisis, emergency departments, otherwise? Great, welcome. Hope you can find this interesting. And those who are not, this is a 200 level, so the assumption is that most of you have a pretty good sense of who a transgender person is, could appear as, and how they identify. So remember, this course was designed for those who probably don't have that experience. So you'll see some slides you're probably like, okay, yeah, get past this. We've seen 5 talks about this introduction background. But the course objectives, as they would be for the actual course, are as follows. What exactly does it mean to be transgender? What special consideration should be made for people who identify as transgender? What risks do they face in the medical context, psychologically, and socioeconomically? And then how can I, as a medical professional, appropriately respond to a transgender person in crisis, both in the ambulance setting and also in the early triage in the emergency department? So this part is what I'm talking about. The introduction of how sex, gender, and expression of that are actually separate concepts in the theory that we all pretty much operate under today, as that's understood today, and those things can be on a binary spectrum or can be in another category. Now the next 2 images I want to, there's a caveat here. This image is very familiar to many, and many in the transgender community have identified this as probably a little bit passé or even a little bit inaccurate or even offensive given its background story. I don't purport to say that I know all the ins and outs, but I wanted to make sure that you all knew that we also are considering this image, which has become more popular, especially on college campuses in the last 3 years, as an explanation of how gender identity, gender expression, sex assigned at birth, and physical attractiveness, emotional attractiveness are termed. These are more current terms, although I think the spirit of this and this image are equal. This has been used for maybe more years to help people who are not in the LGBT community understand where we're coming from, and this is a little bit more recent, perhaps more accurate. But in the course to come up, I'd like actually, if any of you have opinions about these 2 images or which is the more accurate one, derived from personal experience, professional experience, I'd love to hear about after the course. We move on in this training to talk about all different terms, and this is where Alexandra, I want you to speak a little bit about different terms.
So I mean, I'm sure everyone here is familiar, but we basically go through the terminology and some of the main points. With RuPaul's Drag Race and other, the popularity of drag bingo in the area, right? I think people get confused that like me being a trans woman doesn't mean I'm a drag queen, and not all drag queens are transgender. So drag is for entertainment. Cross-dressing is more just for that thrill, where transgender is more that sense of being, and being and identifying and expressing yourself as your true self. And the rest of it's just terminology. And then we touch also on queer. as a term, where that in the past had been more negative. Now it's almost more like an umbrella term. If you say you're queer gender or queer in general, that just eliminates you having to define what you are exactly, for all the different criteria, like this is my gender, this is my sexual preference, this is this and that. And you just say like queer, meaning you're not the norm of a binary or what the typical norm is.
Right. So yeah, this is for people who've not really heard queer being used in anything but it's a negative context that it's now embraced more often. And then we have this part, for this slide's more interactive. We actually asked the room, we won't ask that today for time's sake and because you probably understand this person's not presenting as someone on the typical spectrum, male or female, but it's maybe a blend or other. What do people associate this image they see with, or some terms that they might throw at it, or some adjectives? And we asked them to think about how there's a human tendency to instantly see this person. And in classes we taught before, I do ask the participants, so what's the actual sex of this person, do you think? And they say, well, it's a female. I'm like, how do you know that? And they say, well, the cheekbones and the breasts are present. I'm like, well, yeah, biologically we were all, and as a race, we're tuned in intuitively to see differences and make categories, but our society tells us what those categories mean and how to block them in. So just kind of breaking down that sex, gender, and expression happy linked is part of what this exercise is for. And then a subtle exercise for thinking, we'll go over that too. Part 2 of this presentation, it's a little bit meta. We're talking about the presentation as you're getting it, but anyway, moving on. We talk about experiences that transgender people may have, how it impacts their lives, and in a medical context, how could they be at greater risk. And so I want Alex to jump in again. This is all part she talks about.
I'll just stand up when I'm going to talk.
You do that, you jump in.
So then, on this one, this is a part typically where, I'll cover just to give more of like a personal perspective. And, biggest challenge, right, is, we identify and we want to express a certain way. We want to just live our life. But, we have a job, we have friends, we have family, we have a faith community, maybe, if we haven't already been kicked out or hurt in some way and left the church. But, so like for me personally, post-transition and having all those things, like mainly having a job, maintaining a relationship with my children, right, were the most important and the most scary to me to the transition. But, beyond that, it's just other stresses, right? Now, how do I do dating post-transition, right? That's a more personal thing that can evolve over time, right? I don't need to get married immediately after I post-transition, right? It's just, you have relationship issues dating, right? But those are just normal things that you have if you're trans or not. So, so there's nothing specific there. It just, maybe it's a little more complicated, but nothing that good communication can't help. And then passing is, that's something that creates a lot of stress. It would be nice that society, I use the example, I go to Sam's Club and you show your ID when you go in. So the ID doesn't have a photo, it doesn't have a name, right? I'll go from work, so I'll be dressed like this. And the greeter will say, "Thank you, sir." And I'm just like, and I must glare at him and or roll my eyes or something because, but it's just, like from my perspective, yes, I let it go, but two, it does bother me because can't you see that I'm leaning at least 51% more female than male and kind of just give me that benefit of the doubt, right? It's almost like, they score a point because they knew, like they knew them, So, so that's the unfortunate thing with most of society. It just seems like they know and they need to let the world know that they know and you know that they know. So, so that's some of the things I shared on this one.
And I also add that there's disparity among people who are transgender in their ability to access those therapies, those clothes, those makeup even, to allow them to look the part, if you will, and that affects their treatment. And even on the scale of varying degrees of acceptance, some people are really, this is a lifelong journey. Everyone's going on a journey of personal acceptance. someone who's in your emergency department may, of course they're in distress, so all their worst demons are out, their anxieties. So they're worried about their appearance, obviously. They're worried about their health, their safety, so they might not be totally in a comfortable place anyway about themselves, and so they're gonna be really, really sensitive to how you receive them. And then remember that, if family are involved or present or coming, that's gonna affect them because maybe that's gonna lead to conflict too, and then how we as medical providers may or may not block them into a certain category when we're treating them. We can't ignore, even though the situation that's going to be the situation on them in an emergency setting probably has nothing to do with their gender or sexual expression, but it can get in the way. And that's one of the main lessons of this course, is not to allow how they present or how they call themselves to get in the way of how you give them care, which is in medical context. So minority stress model, society puts stigma, there's lack of rights and support in government and local ordinances, violence and health issues lead to stress. From the National Transgender Discrimination Survey, we have this data. It's the type is too small to see, but the first column is male to female, then female to male, all trans averaged, and then those who consider themselves gender nonconforming weighed in on how many experienced refusal of care and how many postponed their care due to fear of discrimination. And ironically, though almost half were out to all or most of their medical providers about their transgender or gender nonconforming status, 23% of those had experienced some care denial versus 15% of those who were not out experienced care denial. So there was more denial of care by being out than maybe even hiding it, which seems backwards, but can be very true. I got some more studies recently. This is in Ontario, so done in 2017 or 16 to 18. Those interviewed in Ontario as 408 transgender people said that roughly a third had needed to go to the ER. 71% had gotten there, but 21% had avoided the ED based upon their being transgender and feeling they might be treated negatively. More than half, just over half, had a negative experience, and usually it was around the kind of language used to describe them, or their provider just not knowing what to do with them, essentially, in their situation, which may not have even been related to their gender or sexuality. And then finally, more than half had to educate their providers, and that's where we need to come in with education, hence this course. Another survey, this is a US study. They interviewed people and they pulled themes from the interviews, and these two themes emerged. Self-efficacy, kind of encapsulated by the question, this is a transgender or gender nonconforming person asking themselves, is it safe for me to be out in the ED? Because self-disclosure, as the other study revealed, can be a negative or positive experience for you, whether it's known before you get there or you decide to disclose then. And then how there's inequity, and this is true. My status as a doctor gives me more power than you as the patient, and I'm trying to be conscious of that in the way I respond to you and you respond to me. But a lot of negative experiences came from lack of experience, discomfort on the part of the provider, and then being just misgendered, which is a great start to a bad outcome if you don't gender someone correctly. And the question being, if my provider lacks awareness, can I advocate for myself? And I'm powerful enough to do that. And then finally, they also noted that when providers failed to tell the transgender or gender nonconforming patient in the emergency department why they were asking certain questions or why they were doing certain exam maneuvers, why they were inspecting certain things, it inevitably led to a bad experience. So if you don't introduce what you're about to do, assuming you're sensitive to the idea that asking about sexual history can be complicated. So you ask open-endedly, rather than saying like, oh, are you married? And like not be the start of your sexual health history, starting with like, do you have a romantic partner, for example, or doing an exam that's entirely unrelated to them being in the emergency department. Like if they're there for an auto accident and you're suddenly down the genitalia for whatever reason, they had no complaints there, which was highlighted in this study. People had said like, I was examined and my dress was left open for 5 residents to come by and look at. And it was like, wow. So to ask the question and encapsulate this idea, was this part of my exam necessary? Could be a thought in the mind of a transgender or gender nonconforming person. Outside of the emergency department or medical context, violence happens. Well over 20% of transgender people are homeless. Suicide rates, as you add more minority statuses, we know suicide rates go up, addiction rates go up. In Pennsylvania, we know the unemployment rate is twice that of the national average. and then the poverty rate is twice that of the average for our state. This encapsulates the kind of topics that lead to health disparities and problems. Clearly, STIs, sexually transmitted infections, are a health issue, but we don't often, especially when we're going into a room, actually, and we're going in, and the chief complaint is chest pain, think, is this person housed? Does that impact how they're feeling today? It's hard to put all these things together, and when you're trying to be quick, efficient, meet all your goals as an emergency provider, or when there's something glaringly obvious, like a bleeding wound, you're not thinking about all these things. But these contribute to where they might have come, how they came to you that day. I, as a primary care doctor in a clinical context, outpatient, do think of these things more often, but I'm not in an acute setting, so I know it's harder to do so. And then Alexander can talk a little bit about transition-specific medicine.
So 2 main points that we go through what these are, but the main points are, just because someone did one of these or all 4 or 2 of them in different order, it doesn't make one of us like, technically did we complete transition or did we not complete transition, or am I really a trans woman now because I did X and Y but I didn't do Z, so there shouldn't be any like required course or required changes that you have to make, to please anyone other than yourself. And then the other thing is, obviously, you come across like the medical system. Like I had transitioned, but before I changed like my ID and work transition, my insurance was male, and I was presenting female. And then once I did transition, right, then insurance starts sending me all these preventive screenings that are more female specific, right? So it really gets complicated. Like what records do you keep? And then what tests do you recommend based on, kind of what parts you have, keep it in a simple sense. So, it's almost like different record keeping needs to be kept, and maybe it can be something that can be done more general. And then the care can be, more focused, to the appropriate risks that go with, that individual.
And then the last part of our 3-part presentation is case-based. We're going to look at cases that are based upon actual events or events that could happen given some risks that actually do pertain particularly to those who are transgender, who may be undergoing certain kinds of procedures or treatments that do affect their bodily health, not just their mental health or their affirmation of themselves. This part we have the group read together a story, which if you did grab a handout, maybe you didn't, in the front of the room today, you have a copy. It's a half-page paragraph written by John Patterson, and he elaborates upon an actual encounter he had. You can read that to yourselves now or after the class or whenever you feel like I'm boring you. Look down at that, hit your phone, and we'll skip the part about reading it together. But it's a really good story that launches into this section because it is someone's personal story. Whereas the next cases we'll see are designed to encourage discussion and did not actually occur. But so this is the part where we actually get down to brass tacks and the importance of asking the patient you see in front of you what their preferred name, or if you want to say preferred name, what's the name you use, and the pronouns that you use. If they're with someone, ask who this person is, but don't assume it. Don't assume by behavior or they look opposite. They must be, a heterosexual couple. And then when you notice a difference, which you're bound to when you see someone, or maybe you wouldn't expect it to see someone, a difference in someone who's transgender, don't point it out and use terms immediately, but ask if it's okay to explore that or to ask questions about it. They may or may not let you, but you should ask first. In all cases, in all people, and what we came to do in medicine was to be respectful and to meet people where they are, which is usually in a place they don't want to be, literally, the building they're in, or the bed they're in, or the state of health they're in, they're vulnerable. Knowing that these things will be more sensitive and will come out really can help someone step back and say, I want to reflect respect regardless, and follow along with their terminology. So to get this, for in my band or my kind of person, a medical provider wants to learn through cases. So we have 2 cases. I'll go through them really briefly. So this is you as an emergency medical service person approaching an 18-year-old, appears to be male, involved in a motor vehicle accident as the passenger. You arrive and this person's unconscious, and you bring them onto a stretcher into your ambulance. You get their vital signs. their heart rate 65, their blood pressure a little on the elevated side. So far though, nothing really out of the ordinary, maybe breathing a little bit quickly. You throw them on 6 liters or what have you of oxygen by face mask, and as soon as you get that IV access you're looking for, they wake up. And you ask their name, they say, I'm Ezra, where I'm from. You get the driver's license from Ezra, and they identify date of birth is correct, height appears to be right, but the discrepancy is the name on the driver's license is Esther. En route though, I mean, you're like, huh, that's interesting. But en route, they get tachypnic, or they start breathing faster, or having distress in their breathing, and their oxygen saturation drops below a good level, 88%. Not that great. Great if you're passing a test in science class, but not for your breathing. You're like, yes, 88%. Not good for breathing. You remove their outer garments because you're about to do something interventional on them, and you see this. Now I'll ask someone in the room, for real now, they would know the name of this garment. A binder, a chest binder. You stop, because you've not seen this before, or imagine you've never seen this before on somebody. So what would you do next is the question. The answer for people who are in the room usually is, well, I'd get that thing off, especially if they notice it's very constricting. And I'm like, well, how would you get it off? And they say, well, do you know it's a very thick, durable piece of material? It's certainly not going to go over their neck or over their head or down. And they said, well, then I'd be cutting it off. I'm like, well, okay, we'll talk about that. So what would be, for anyone out there who's maybe experienced this, knows the way around a binder, what are some difficulties with a binder? Or some things that you have to be aware of when you're wearing it or handling it?
I would imagine they're expensive.
Yeah, they're not cheap. Customized, probably. Yeah?
They are difficult to get off, and also the longer you wear it, more sort of generalized somatic sensations can be felt as like unpleasant. Like, you know, over time you'll develop. Sometimes people have like difficulty breathing with one on, or like abdominal pain or chest pain as a result of binding can develop as well.
You're right. You're right. And in this setting where a person's suddenly in breathing distress, you want to get as close to their chest as you can. This is in your way. So the perception is, I mean, what are you going to do? What's more valuable, saving the garment or saving the life? Obviously the life, but one respectful way, yes.
Well, I was thinking also that the person might not be prepared for you to see them like that, so they may be even panicky breathing or getting worse because they're either flipping out or getting more anxious and distressed about it. So that could be a whole nother problem.
You're right, that could come along too. So I try to instruct people toward, and maybe you're already thinking along this way, that yes, of course the light is more important, but the garment may be very important to the wearer. And if you have to destroy it in the process of saving your life, okay, but save it or hold on to it and bring it back to them and say, hey, you know, we took this off of you, but I want to just return it to you. Because it might be important for them to see that you honor that piece of them that really keeps their identity in focus. And of course, once that's off, perhaps their underlying bodily identity or the visual identity is something that comes up, and they might be treated differently from that point onward in their ED visit because they don't have that to affirm them. All right, the next case, now you're in the emergency department. This is someone who walked in rather than rode in. Your triage nurse reports to you, Andrew Bowles, 48-year-old male, bed 5, swollen right leg. You're going in the room to introduce yourself and do a brief history on the patient, and you say, hello, and they say, hi, I'm Angelica. How would you respond? Hi, Angelica. Yes, using the name they gave you or the terms they gave you, you continue. So you ask to confirm identifying information. Oh, okay, well, what's your last name? And date of birth, like 2 identifiers, don't have to be the first name. Honestly, there's lots of ways to identify a patient. And you continue, and then so Angelica says, I woke up with a slight pain in my right calf today. Halfway through my work shift, I couldn't stand any longer. I pulled my pant leg up and I saw this. You have the swollen right leg, lower leg. What other questions do you need to know about Angelica from what you've seen and heard so far? Anyone who's medical can certainly chime in if you'd like to. What other information do you want to know?
Medication list.
Medication list.
Recent surgery.
Great.
Recent travel.
Recent travel.
Prior blood clots.
Any history of blood clots? Good. Anything else?
Onset of pain.
Onset of pain. That's good.
Allergies.
Awesome. Yeah, there's the whole gamut here. Many of you are identifying the diagnosis we were leading you to, and that's important. I would add smoking. Hey, where are we? Risk factors. All right, so you do an exam, and the only important part really, just a couple things to throw people a little bit in here, but the calf is big. There's big edema, meaning you can push your fingers in, and when you pull them away, you have an indentation on the leg, meaning that there's fluid in the legs, the skin of the leg. You don't feel a mass there, the skin's attacked. And then you do an ultrasound, you get this. So now, this is actually in a word a little bit, but what further questions, if assuming Angelica didn't give you any of that information or maybe glossed over some features like her medications, like, oh, I take a blood pressure medicine and my Zocor. If you found this, would you then go back and ask anything else?
Any hormones?
What's that again?
Any hormones?
Yeah. Yeah, and how would you, in a sensitive way, ask, are you on hormones or birth control? And that's a discussion you would have. We can actually do that at the end, but here, this is adapted from the WPATH standards for hormone treatment. These are from the highest risk to probably the least confirmed risk in feminizing hormones, that being primarily estrogen derivatives, and masculinizing hormones, and those that promote those hormones or block other hormones. The ones in bold are the ones they considered by their study to be the most medically significant possibilities. As you can see, deep vein clots are up there on the feminizing side of the hormone, but these other conditions are more about long-term primary care risks, not emergent. But assuming you may have done a blood cell count in someone who's taking testosterone, you might see that they are polycythemic or have excess red blood cells, and that shouldn't throw you, but maybe should point you to asking more questions they might not have felt comfortable revealing at first, that can lead to the risks you see. All right, so the lessons we get from cases 1 and 2 really aren't just the medical, like, oh yeah, DVTs, estrogen, right? No, it's more about check your immediate reaction to a situation, and remember that respect is always to be your goal. Being open-ended in your inquiry first before you narrow it, so you don't cut them off at the pass before they get a chance to talk about what brings them there, the risks they have. Use and reflect the names they give themselves. Consider their pronouns if they offer them, or offer to ask, what's your pronoun preference? And then consider that this person is in a context of past abuse. If they're transgender and they brought that to you or you know it, you can almost assume they have some sort of societal, familial, personal, other stressor on them that has led to some things you may be seeing or hearing about. And it's not their fault, but it's something that is part of their situation, as with anybody. And then once you get all those things in order and you reflect your respect, you can then proceed to take care of them effectively in the ways that help everybody out. All right, so those are our objectives. We started the whole thing with references and our thanks for being here. We'd love to hear your questions.
Yeah, so the one question, or you had asked about how do you ask if they're on HRT? Like for me personally, like you could ask me like, do I take, or what have I done, if you wanted to ask about surgeries, like what have I done to affirm my identity? Or do I take any medications? Or what have I taken to affirm my identity? And that should lead the person, right? You know, beyond that, you may have to get more blunt, but you know, we're all pretty aware of what we've done to transition, you know, or to affirm our identity. So,
is there any certain things that you've heard that have just really taken you to that place of complete disrespect? I mean, can you think of? I could think of some obvious ones, but is there something you've experienced that is just please don't go there?
I mean, there's the real rude ones, like, you know, like if they find out I'm a trans woman, right? You know, they say, oh, I can't tell you were a man, or, you know, or someone saying, oh, you look more like a woman today than you did last time I saw you, or whatever, right? Say you go to a doctor's office on a routine basis. Some of my personal things, like, you know, just going to like the pharmacy, I'm there to pick up like HRT. The person at the counter, it's not there, so she yells back to the pharmacist, you know, and at that time it was before I transitioned fully, so I was there as male, there for estrogen, so she just yells and says, he's here for his estrogen. I mean, it's not specific to me. I mean, the guy, like, before me, you know, if they yell back, you know, he's here for his Viagra, he might not want everyone in line to know either, right? So some of those things I'm kind of shocked at. Obviously, I'm more sensitive to it, right? But, I think some of those things, would be common for anyone. Yes.
Just a comment too. I primarily work in like a more outpatient setting myself, and I will say like in terms of navigating the conversation of like what steps have you taken to affirm your identity. If you're asking medications and like accurate surgical history, you just did it. You didn't have to do anything extra. Like that's if you're taking hormones, you're gonna listen to your medications. If you had surgeries, you're gonna listen to your surgeries. There you go. You don't have to ask any different really.
Yeah.
Yeah.
Sometimes though, and this is what I've heard from people who prescribe, some people don't think of their hormones as being medicine. But then again, some people don't think of taking like a ton of St. John's wort as being a supplement. When I ask them, what supplements are you on? Nothing. Later on, yeah, my vitamin C and my D and like and it's like, okay, wait a minute, you told me no supplements. So always yes, there'll be people who will flub like their ideas of that. But asking more pertinent questions, if there's a historical point that would point to that having transition, you may want to back up and say like, do they any hormone therapy in the past, or or some other way that would be more sensitive? If you could talk about how you affirm your identity, and they haven't mentioned it in the first pass through your medication list.
Exactly.
Yeah, and a lot of the hospitals are trying to like modify their medical system so they can record like preferred name or preferred pronoun, as opposed to the medical or your legal name for insurance purposes. But that happened as well. Like I went to an affirming doctor, and still they would come out and yell my male name or vice versa, and I was presenting the opposite. So, and then everyone looks in the waiting room, So it's just awkward, and it happens more than you think it should. But that's not life-threatening, right? Now, if you're out somewhere and someone attacks you, for being transgender, or right, or someone like is aggressive towards me when I'm out at night or something, then that's much more of an issue for me personally. The other stuff is more an annoyance, like the Sam's Club guy, But I bring him up a lot, so he doesn't really suffer. But thank God he's not there anymore. He wasn't there last night. So a woman was there, and it worked so much better. So. Any other questions or comment?
I guess like how are EMTs, like how are people responding or like reacting to this training? Like are they open? Are they resistant? Yes, good.
Way open. By a sample size of a class of 30 or so, we've done one other time. Yeah?
Oh, I was going to ask how widespread is this training? As I was credentialed, I think mine expired in like 2010, and I was like, oh man, I wish I myself had seen this like at the time.
Well, it's received in December, it received the go-ahead to be CE credit for EMTs through their system. We advertised it, it's being taken up in multiple counties, working with AHN on it, trying to get it in their hospitals and with some of their residents, and then Allegheny County EMS is also trying, in the fall we're going to try to spread this around more. But thus far it's been taught in one official context, but it's been piloted in 2 others, and beta tested. Always received wonderfully. They wanted us to come out to them. Not in that way, but come to them. We were already out. I was like, at the beginning, I'm like, hey, I'm a gay doctor, and this is my transgender helper. We try to like that's at the very beginning, but it has gotten really warm reception.
That's great.
So you can contact the Washington County Gay Straight Alliance and we'll connect you.
Oh, cool. Thank you.
How much do you charge?
I think that would be
What?
If you're in a township, how much do you charge for the training?
This is a free training. If it's being done for credit, they get their CE credits funded so they can, as part of their employment. We don't charge for this.
I'd like to recommend this program to our township supervisors for our EMT.
We'd like that.
Right now, we're still working under a grant from Three Rivers.
That's why we give them the visual shout out. They did fund this or the creation of it. Yes.
I know you don't have a large sample size, but I was wondering about if especially emergency responders ever fall into the assumption or trap that there's any brain damage or head trauma when someone may give a different name than say their ID says, or information that's contradictory, if that is something they would need to be aware of as jumping to an assumption about.
That would be an assumption to jump to if you only ask name, but you should probably have a conversation about like, hey, how you feeling? Where were you tonight? And then get a sense of like, if they can't verbalize anything, then yeah, probably brain damage. But if the name's different, that would be a too limited interview.
Yeah, the feedback like afterwards, I mean, so many people were positive, both as the EMTs, the supervisors of the EMTs, so that was really positive. I also had the luxury to speak at the Emergency Nurses Association, their national or international conference. It was downtown last year, and there was about 1,000 people there. I only spoke for 15 minutes because most of it was about marginalized communities of poverty and homelessness, but they did a little part at the very beginning on gender. But I stayed after the other talk was done, and there was so much feedback, and so many people were concerned. They were doing good, they wanted to do better, and they were very interested. And around the country, there are a lot of good things happening in different medical systems and facilities. So I was actually really happy about that. So the feedback is really good. But a lot of it's just awareness and education. And that really applies to pretty much all of society. You know, I've never had anyone, after they're informed, like still be aggressive towards me or still say, you know, that's sick, or, you know, they're just kind of like, yeah, I understand. It's not a big deal. You know, we just want to live our life and just move on. You know, my kids finally came to that resolution, so it's all good. It can happen. So, but yeah, go ahead.
We have 2 minutes, and we'll take this as our final.
Just asking. I know this was geared towards EMS services, but I'm also talking about questions about first responders, like police. Is there a subsection to this, or can they attend this as well?
I think it's the actual CE credit that I spoke before goes to EMS workers. I don't think police are necessarily under that umbrella.
Because sometimes they come together.
They very much do.
Yeah, so I'm just making sure that our first responders
we would not hold this
sometimes
back from anybody in police or fire.
Or is there a separate training for police officers,
Not
law
just
enforcement?
yet.
Okay.
Our PFLAG Pittsburgh group, we have like a speakers bureau. In the city of Pittsburgh, we do go in there and talk. The police come through in like groups, and it's almost constant. But we go and give awareness. I mean, that's all of LGBT, but at least it's awareness for the police officers. And that's through PFLAG Pittsburgh.
Will they come to Fayette County because people usually don't like to leave Pittsburgh?
Yeah. Yeah, I mean, with going outside our area, right, then it just kind of comes down to travel costs, right? If it's close, it's not an issue, right? If you're going to Erie or somewhere farther, right? But yeah, we have the funding through the foundation now, which allowed us to develop it and do these initial presentations.
Speaking of feedback, I want to plug that if you grab a packet, which is only 2 sheets of paper, one of them is our personal class feedback form. If you could finish that up and leave it on the same chair where they were originally, it's anonymous. We just want to know, how can we improve this? Because we're still, every time we teach this, we want to improve on it. So, thank you very much for your attention.